So as Niraj said, he had an idea for academics, and you turned it into an actual policy. So, and you had to actually, make it work. So can we just start off with what is it that you did? Right. So what is the innovation that you are now undergoing?
Sure. And before we start, I just want to thank the Brookings Institute for having us today. I am most certain that this is probably the first ever session called Louisiana Innovation here at Brookings. It's wonderful. So here I also want to recognize my boss, Governor John Bell Edwards, who through the Medicaid expansion made it possible for us to think about these types of things. When we think about eliminating a public health challenge, if you don't have health care coverage for individuals, that you don't even have a conversation about it. So it was the Medicaid expansion in January of 16, which was his first executive order, that started this conversation, and him saying to me, Rebecca, you have two jobs. One is to expand Medicaid, and two is to make people healthier. And of course, we have the best food in the country. I don't think you can argue with that. So we have a lot of, as a result, we have some health issues. We have significant challenges. We have, in many of our indicators, we're 50th most unwell, although some of the happiest people in the country, if you look at BRFSS and CDC surveys. And so really looking at, I want to get into why. So why did we do this? So drug prices had vexed me for some time. I'm an obstetrician and had previously run a birth outcomes initiative to try to reduce infant mortality. And the one drug that is able to do that is 17-hydroxyprogesterone. And it went from $9 to $900 while I was trying to do my work. And and the drug price, frankly, made it impossible. We did everything, created a national quality measure, relieved every barrier to access, and it was simply, the price was simply in the way. And so starting in this role, although I'm not a hepatologist, unlike Senator Cassidy, who's been our partner, but the first month on the job, I got two letters. One was from CMS saying you should provide more drug for Hep C, and the other was from advocates saying you should provide more drug for Hep C, and yet we had a $2 billion deficit. And so the previous administration had left our budget in shambles. We were looking at, could we continue to cover nursing homes? Pharmaceuticals are an optional program under Medicaid. There were draconian cuts that we faced, including to higher ed and K through 12. And so more Hep C drug was simply not possible, or much more higher spend on it was simply not possible. So we aimed to come up with a new way of doing it. And the pitch was always this. It was never about just a slightly better price or a better deal. It was that, here we are in this country. I think Niraj so beautifully illustrated this, with a disease that kills tens of thousands of people. It is a leading infectious disease killer of our time. And through, in large part, the innovation of Americans, our research institutions, we have a cure. And it's unacceptable that in this day and age, we cannot provide it, and we have people suffering, bleeding internally, and dying unnecessarily because of the price, just simply unacceptable. And so we set out to solve it, and frankly, we were agnostic to the solution as long as we were able to provide individuals with access, and the governor supported me and my team. And I think that's very important. As we started this journey early in 2016, many states were not willing to join because there was fear of change and how the pharmaceutical lobby would relate to this type of thing. And so what we did achieve last month, and what started last week, which was wonderful to see, and we've already treated hundreds of patients who have been waiting, is the modified subscription model. To some effect, I think there was one of the things we navigated was that there really wasn't an understanding of Medicaid policy as you looked at applying this to a state context. And one of the challenges we have as states is that we have, as you know, Medicare is a federal program, really mostly federally run. Medicaid is a state and federal partnership, and you've seen one Medicaid program, you've seen one Medicaid program. But everything we do, by and large, has a federal component to it, and so everything we do has to be under state plan. And so we are not able to just write a check to a pharmaceutical company because there's no vehicle for us to do that and get our federal match. And so we had to find a way around it. What we realized, and I do want to recognize the Trump administration for their help, is that working through Niraj's idea, that of Senator Cassidy and Peter Bach and others, of course, there were many other ideas over the course of the 3 years that we tried. We realized that the best price that you could get around the best price considerations that Neeraj outlined if you enter into a supplemental rebate agreement and if an entity is a 340B entity. And so that's what we realized. And
340B is.
So 340B is a discount pharmaceutical pricing program that was created to allow safety net institutions to have revenue stream, to allow vulnerable individuals to be covered. And so many of federally qualified health centers have used it. There's been a national debate about hospitals using it and our entities that are benefiting really most appropriate. But we realized that there were these exceptions to what is important, because what we knew was that a state like Louisiana, a state of 4.6 million people, that no pharmaceutical company would give us a deal that would then impact their entire national price. So we had to get around those considerations, but we also had timing as an issue. So we started this in June of 16, and I'm now 100 in secretary years. I've been in this job nearly 4 years, and so we didn't have time to do, as we discovered all of these, went through all of these hoops, we didn't have time for a waiver. And so we looked at what could we do under existing policy. So what we have now is a modified subscription model. We're up to a cap, which is at or about what we spent last year for Medicaid and corrections. We will then get unlimited drug, and then we will be able to eliminate this infectious disease and focus on more difficult challenges. So we're really proud of that. And last week we started. Patients are now getting drug. I saw a mother last week who had to go through 2 pregnancies with hepatitis C, worry about whether she would give it to her babies, worry about whether she would die from this disease. 60% of people who have hep C have liver disease. 1 in 5 get cirrhosis. 1 in 20 get cancer. So it's a very scary thing to have to live with. And we've seen hope for the first time in many, many people who have waited years. And so all of this has been worth it. And we're excited to be able to offer that now as of last week. And then corrections, not just for Medicaid, but in corrections. We know that we think about 30% of people with hep C will pass through a prison during their lifetime. About 95% will get out. And if we aim to eliminate this disease, we can't ignore them. And so we're really, really proud to be the first state to be able to offer this unlimited access to individuals who are incarcerated.
So that sounds fantastic. And it sounds, you just do the waiver, the rebate, and it sounds easy. Like, okay, now we know how to do it. From what I hear, it was not easy. So so who did you have to ask permission from, and who did you have to convince, and what arguments did you face, and how was that?
It took 3 years.
Yeah.
A little more than 3 years, because June 16 we started. First of all, the governor, to have his support and to have the support of my team. We were told no at least 50 times from a variety of people, whether it was the industry or policymakers or individuals at the CDC or variety of reasons, because it had never been done before. Now it looks like it was an easy thing, and it seems intuitive, but it was not. And I think another important thing that Neeraj brought up is as over the course of our journey, it became a competitive market, right? And so there then became an economic impetus to enter into this kind of agreement. But the first thing we did was outline the trade-offs. And I don't know if Josh Sharfstein is here. He was one of the early partners. But Peter Bach, who I knew from the Health Services Board at the National Academy, I called him up one day and said, we talked about his abacus and how he'd showed trade-offs, demonstrated them particularly in cancer, and asked him if he and his team could demonstrate those for state budgets. So we mapped out the Louisiana budget and demonstrated that it would cost us $760 million at the prices at that time to eliminate hep C just for Medicaid alone, and that would be more than our K-12 budget, our prisoner budget, and all administrative functions of government combined, and that there really are real trade-offs. We have to balance our budgets every year as states. We can't print money or borrow from China. We have to balance our budgets. So that means when costs go up in healthcare, they go down in higher ed. And we thought that was important because the national discussion at that time in 16 was about what a great value this is. And arguably, it is a great value. There are so many drugs that don't work, that provide marginal benefit. And here is the first cure for a virus that I know of in human history. This was a tremendous innovation, but one in which was inaccessible to, as Neeraj said, 3% of Medicaid, less than 1% of prisoners. So, we said, well, this is, although this is laudable, it's a great drug, we can't afford it. And there were economists, Rena, who's going to be next, we were on this panel, and there was a gentleman from MIT there saying, well, just mortgage it. It's like a Tesla. You don't pay for it all in 1 year. And I was laughing. I said, Louisiana's never going to be able to afford a Tesla. We're, maybe a Honda, but we're not a Tesla state. We're the lowest income state. 42% of our people live below 200% of poverty. We don't have paid family leave. We don't have universal pre-K. We don't have other things that are meaningful. So, we just were not in a position to pay the price that it was. So we then asked the question, and Josh Sharfstein and his team at Hopkins helped us, what about Federal Patent Law 1498? This is a 1910 law. Most notably has been used for night vision goggles. So if there's a technology or innovation that's been shown to improve the safety or health of the American public, the U.S. government can fairly appropriate the patent holder and then use that technology. Now, we brought this up, could this be used for Hep C?
Yeah.
And we had a conference, and overwhelmingly there was support for it and people that came, but certainly the pharmaceutical industry was less than enthusiastic. So then we said, okay, well, if you don't like this, status quo is unacceptable to us, what else? And so one day I got a call from a man named John Arnold, and it was a totally out of the blue cold call, and Laura and John Arnold Foundation is a foundation that supports innovation in pharmaceutical pricing. And he said, Rebecca, how can I help you? And I said, well, I think I need an offensive line, John. I think that Louisiana, to be the only state asking this question, asking for a different framework, we need a different equation to solve because we won't solve the equation how it is. We need other governors. So we said, and I happened to be at NGA at a meeting for health policy folks, and said, well, why don't we fund the NGA to bring other governors along? And so it was through that, then we brought 10 other governors along. It was bipartisan. It was Charlie Baker. It was Jay Inslee from Washington State. And so they joined us, and we asked the pharmaceutical industry, okay, you don't like 1498, what would work? Okay, it can't be what the status quo, can't be a mortgage, can't be the same price. What would work? We also asked payers what would work, and then our teams convened. And by that point, Neeraj and his team were putting their recommendations forward, and that became a very attractive option because it really should be a win-win. These pills cost dollars to make. The folks who are incarcerated, there is never going to be enough money because incarcerated people are funded totally by state dollars to cure everyone in prisons, nor was there going to be unlimited money in Medicaid to treat. So why not this win-win where pharmaceutical companies could have this guaranteed revenue and yet a state could solve a public health challenge? And so we started to socialize that. But even that idea, as much as it seems like an inevitability, took about 2 years to really push forward. And it was in partnership with Senator Cassidy, who is a hepatologist. In fact, he's only one of 2 hepatologists in Baton Rouge, our capital city. So one of the other pieces of the story is that we've had to think about how we think about treating and testing differently. And Alex Bu is here with me, who heads up our Office of Public Health and has been extraordinary in that regard, thinking through that. So we had Senator Cassidy, we had the Trump administration and others, and then slowly over negotiations, this became a viable option. Now, last year in September, we released an RFI asking folks what they thought of this idea, and there was a lot of support. Pharma was supportive, Gilead was supportive, AbbVie was supportive, and then after that, we did a SFO, or solicitation for offers, and asked the companies to come to us with their proposals. And it was only Asegua Pharmaceuticals, who is the subsidiary of Gilead, that had a real subscription model, or the modified actually what they initially envisioned as a subscription model, but we couldn't do because I can't write a check to a company that we then negotiated as a modified subscription model. So, I want to recognize that company because they were courageous, to be the first company in the nation to enter into this. There is some risk, and we are, really delighted to have started this last Monday.
Yeah, that's fantastic. So when you talked about talking about the trade-offs, sort of in terms of making the case, was that? I mean, to me, it seems like that might be making the case to the public, but also to pharma, which is to say, we're not. It's a negotiation, right? We're not kidding here. We're actually not going to buy more, right? Because we can't. Whereas, the case about it's really worthwhile investment. Well, you actually have some unique the balanced budget requirements that make that, so what, in some sense, to you guys? It may be a great investment. We still can't, maybe we should be able to afford it, but we can't. So was that the kind of stuff that convinced them to go along? Was it mostly the fact that the competition that Niraj was talking about, that if they did, that this was a way of sort of getting the market? What do you think their considerations were that made them decide that to take that risk?
I don't know if I'll ever know, but we amassed the smartest people, who I call the pharmaceutical Avengers. I mean, the smartest, most competent, creative people in this country helped us. I mean, with no remuneration. I mean, John Gruber, Rena Conti, Josh Sharfstein. I mean, people spent hundreds of hours, calls every week, helping us, just because this is the right thing to do. I mean, there are very few things in your career, in my career, I think I'll be able to say, certainly the Medicaid expansion was one of them, that I truly saved lives. Just to see the look on that mother's eyes, made it worth it, and it made it worth it for people who don't even live in Louisiana to help us. So, I mean, we had the national best, Niraj. I mean, we looked at every idea, and we were also intrepid. We were not going to take no. I mean, as long as I had the ability to have this role and to fight for the people of my state and my governor, we were not going to take no. We were going to fix this problem. And so I think that they got tired of us too, probably. but I do think, again, I think there are people like Greg Alton who has been an advocate for patients. I think Gilead has been in this space of trying to solve these issues of access globally. Typically, though, these solutions have been applied to other countries, right? So we look at Egypt and India. Although Louisiana, often our economy looks like a developing country and our health challenges mirror those of some developing countries. Those solutions had not been applied to the U.S., but I think it was all of those things. That was having a company be willing, having the brightest minds in the country, having stubbornness, and not, if we had given up the first time we heard no, that would have been in 2016. So I think it's a variety of things, but we'll hear from Asegwa next, so
yeah.
I'll say.
And in terms of the challenges of sort of the getting through CMS, like what was that partnership like? What was that? Did they say no at first too? And how did that come about?
Yeah, I mean, CMS is fantastic. I just can't say enough. We're working with them now on a model to help spread this through CMMI and Adam Bowler to look at other states, because there's now a lot of interest. Their pharmacy team got down and dirty with us, rolled up their sleeves, and tried to look at what the solution was, and were very constructive. So I just can't say enough about how great they were. And also understanding that we were in a rush, right? Every patient who gets sick or dies or gets cirrhosis or cancer while we're trying to figure this out is a failure. So we always had that pressure, not just of political timeframes, because my governor's up for re-election this year, but kind of moral imperative to get this solved. And so they were right in there with us. So I think that some of the we don't need a waiver to do this. Okay, so I think that's for other states. This is something you can do through a supplemental rebate agreement. So I do think that that figuring that out would definitely lead to other opportunities, not just for other states to do Hep C, but for other disease categories as well. But I think it should have been, I think this should have been done earlier, but for whatever reason, we were the first state to think about this.
And you chose Hep C because of that timing, because it was so important to do it quickly, or was Hep C a perfect case for this, or why Hep C?
It's the leading infectious disease killer in the U.S. Kills more people than all the 60 infectious diseases below it kills combined, and we have a treatment. And so, this is an epidemic. Also, we've had in some communities throughout the country hundreds of percentage increase points in number of infections. We have younger people getting infected. It is arguably the most important public health issue dealing with pharmaceuticals. Now, we're certainly concerned about prices when it comes to treating syphilis and prematurity and so on, but there are just so many people that have this, and so many of them are untreated. And the other challenge that we had during this journey, frankly, was to be successful. We're going to be successful at elimination. We're going to have to find and treat tens of thousands of people, but we couldn't do that until we had this agreement because we didn't want to give people false hope, right? So we didn't want to go out there and say, oh, get tested, get treated, gonna get your meds, and then all of a sudden it fell through. We couldn't do that. So it's been a challenge on the public health strategy side while we plan the drug pricing strategy.
So how popular is this in Louisiana? Do people know about it? And it was like, is it more popular for Medicaid population than the prisons? Is that any issue at all? Or like, what are the politics of this?
Yeah, I mean, I think these are vulnerable populations. You know, this is a disease that impacts vulnerable populations, and our journey has been to really address this. And individuals who are incarcerated were always central to our thinking, and I think that's one thing that also distinguishes Louisiana. Until my governor came into office, we were the number one, the highest rate of incarcerated people in the U.S. Now we're number 2 or 3. So this is a really important issue for us, and I do think having Senator Cassidy, who's a hepatologist, be supportive was helpful. People understand that the long-term costs of this are tremendous, both in terms of cost to the Medicaid program as well as cost to society. And also people support the fact that if we know that 95% of people who are incarcerated will re-enter, we want them to re-enter healthy and ready to work, able to work. And so, I think it is very, I don't have a poll,
yeah,
but certainly we've had a lot of support, public support in Louisiana for it.
So you just treated your first patients just last week, you said?
Last week.
Mm-hmm. So now looking forward, so you got what sounds like, the hard part done, you got the price down, so you have the ability to treat, right? You have the supply side. What are the challenges that you face going forward to make this actually successful?
Yeah, I mean, I have 2 hepatologists in my capital city. One of them's our lead clinician, Gia, and the other is Senator Cassidy. So if you think about the current system, which is a really resource-constrained system where we have to document end organ damage before treatment because the cost is so high, it would be an impossibility to achieve our goals. But we're going to have to do this in a totally different way. So we're looking at a renaissance in Louisiana. What can be done differently? We're doing everything from working with IBM to think about how do you create social capital and even do microfinance around if you get treated and you get someone else treated and that person treats somebody else, can we figure out an economy for that? We're looking at how do we work with CVS or Walmart and get people treated through a pharmacist? Can I write, similar to what I did 3 years ago with Narcan, a statewide Dr. Gee's prescription for Epclusa, where you, through a modified relationship with a pharmacist, nurse practitioner, so on, you can be prescribed a cure for Hep C. We've also been working, and a month ago we brought in every viral hepatologist who would come, who's a national expert, to look at a modified algorithm for treatment. Now the algorithms are very complex because, again, they're focused on resource constrained and organ damage. This one is extremely simplified and has been informed by the VA, by UCSF, by Hopkins, and others, so we can simplify. And we're last week also we've been doing statewide education of every doctor in the state, looking at can you get a discount on your malpractice if you do the Hep C education for continuing medical education. So we're going to have to think outside the box because what we have now are very few people who understand how to treat this because the focus has been on you have to get a biopsy or you have to show that you have a fibrosis score. You have to demonstrate complexity to be treated. Now the goal is to treat everybody with this virus. Yeah. So it will take work, and Alex B is one of the best in the country. And also, again, what's happening for us, which has been wonderful, is folks like John and Laura Arnold have stepped forward to help us. We're working with experts at Hopkins, Risha Irwin, and others who have looked at how do you use telemedicine, and other vehicles that are non-traditional for this disease, and we're excited about that part.
Like if I thought, so what fraction of people with Hep C know they have it, do you think?
So in our state, we have 90,000 people who have viral positives. How many of those know they have it? I don't know. I don't know that I have that number. But in Medicaid alone, it's about 37,000.
And this is a population that, so has the Medicaid expansion sort of changed the way these people already interact with the health system? Or do they all have doctors? Or is that going to be even just pulling them into the health system? And can you think of sort of, once you do that, other positive effects coming from that,
Yeah, I mean, we've already done a great job getting people into primary care. We exceed national averages on access to care, primary care. We have a tremendous network of federally qualified health centers. Some of that was born out of Katrina and the need to rebuild medical infrastructure. And so we have done fairly well with access, but we're going to have to get even more creative. I think that the idea is, look under every rock, think outside the box, figure out how to engage people. But the other issue is that people have felt, and as we've been on this journey, we have seen, in fact, one of the women who was in a picture with me the other day was fired from her job after that picture came out in the paper when it said she had Hep C. And so those are the kinds of things when you look at stigma. I mean, we're going to have to deal with stigma, and certainly if something is totally curable, there should be no stigma, but that's part of what we need to address and get to people where they are. If we were to focus simply on getting people into the four walls of our clinics and our hospitals, we're going to fail. We have to go to where they are, and these are people who are traditionally, many of them don't trust the healthcare system, haven't had good experiences, so it's about going to, we legalized needle exchange several years ago, in this administration, so it's about interacting with those programs and building trust with communities, and as we do that, getting rid of the stigma associated with this disease.
Yeah, it's fascinating. Okay, so we have a few minutes for some questions from the audience. We have a mic that'll come around right behind you, Hawen. Oh, all right. Then we'll get you after.
Hi, thank you so much for...
By yourself, thanks.
Hi, I'm Hari. I work with the AMA. Thank you so much for talking about this model for treating Hep C. I'm actually a medical student, so it's pretty cool to hear about the new models to, actually give access to the cure. What I was wondering about is how long does the subscription, contract last with the pharmaceutical company?
Right,
Is
so
it kind of into perpetuity?
It's a 5-year agreement.
Okay.
Mm-hmm. And I'm glad you're here. As a medical student, I applaud you being here.
Hi there, Lauren Canary. I'm formerly with the CDC and had the chance to visit you in November, I believe, in Alex. Now with National Viral Hepatitis Roundtable, and I'm glad you brought up stigma because it's a huge concern for a lot of patients. And I just wonder if other states are looking to this model, in states who have previously had restrictions around treatment based on sobriety or liver fibrosis, what can those states be doing to message patients that they're welcome now, that there will be less stigma, and that they're ready to prioritize their treatment?
Yeah, well, we're going to try to make it cool to have Hep C. Not that we want you to get it, but, if you have it, great, let's just deal with it. I don't know. It's about talking about it. It's about people, seeing people who have Hep C and they look like all of us and that it's okay. I think, again, you have to have unrestricted access, I think, to have that message. I think when people have to wait till they have end organ damage, that's part of the stigma, right? Because people, by the time they find out they have Hep C and are getting treated, they're sick. And so it's all of it. Other states I've had other countries reach out to me. In fact, there was an article last week about England looking at this for antibiotics. And so we expect this to be, again, it would be success for us is replication. We want everyone to be cured in the U.S. I think the next real opportunity here is addiction medicine. Why doesn't everyone in jail in every state in this country get treated for their addiction so they don't leave and have a 30-plus times higher rate of dying because they take the same dose of opioid when they come back into communities without any treatment? So I think that the possibilities here are unlimited. I don't know that we have the bandwidth to do it all right now, but we do hope it spreads, and we're happy. I think that we're absolutely willing to work with other states, and the best way to reduce stigma is for people to speak out and for us to give them a voice, and also that it's curable. So there's no reason for stigma.
Hi, thank you very much. My name's Adam Elshaw. I'm a Professor of Health Policy from the University of Sydney, and I'm a visiting fellow here at Brookings. So Australia started this modified subscription model in March 2016 with Gilead as our partner there. 2.5 years out, we've successfully initiated treatment on 1 in 3 Hep C carriers with a 95% success rate. So we're aiming to eradicate completely Hep C from Australia by 2026, although there is a law of diminishing marginal returns. As you've pointed out, every new patient is harder to find. Can you reflect on how you go about setting the cost, if you think about it as a cost per initiated treatment or per patient? And just to put a teaser in there, it's been said that Australia's paying $8,000 per patient.
So, and I apologize, I didn't recognize Australia. So Australia preceded us. It's a little bit different model, a bit similar idea, and Australia should be applauded for pioneering this. So I can't tell you exactly what our price is per unit, but what I can say is this: our goal, which we achieved, was to spend at or about our annual spend. So that's what we did. So it's already a win. It's a short, intermediate, and long-term win. So what we've locked in is about or at our spend last year. And so that allows us to reduce inflation over time, as well as over time reduce those long-term costs. The challenge for us, though, is most of the time people are on Medicare when they have those costs. So although one of the steps on our journey was to go to CMMI or even go to the Veterans Administration to say, listen, these folks are going to be your patients one day. If we cure them, can you give us money now? And it was just too complicated. But the idea was, not for the pharmaceutical industry to lose money, to maintain at or about what they are making, but for us to have the ability to cure. And our goal is and as is Alex's goal, so it's his responsibility if we fail, 80% treatment. No, but we, if we aim to, what Australia did is great, but we are hoping to do better. And so we're going to have to do everything that you did and more. And for that, again, we're looking to innovative technologies, working with IBM, who has one of their 5 innovation centers in North America is in Louisiana. And we're really, actually 2 of them are in Louisiana, looking outside the box to try to see how to reach people in different ways. And so it's a big challenge. It's an audacious goal. We'll be successful if we don't treat 80% of people, but that's our goal. And why not have an audacious goal?
Yeah. All right, well, we're going to have more time for questions after the next panel, but we're out of time for this. Thank you so much. This is delightful.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.